This module will introduce you to the mainstreaming protocol of Lynch syndrome, a module integrating germline genetic testing into routine oncology clinics. The pathway has been developed to enable clinicians in the MDT to consent patients for genetic testing for Lynch syndrome. This module will last for approximately 12 minutes. This module will introduce you to how to manage the genetic testing result for Lynch syndrome. You have now received the genetic testing results. This will either be available to you in the GLH result portal or will be emailed to the person who requested the test and the MDT coordinator. Once available, the patient's name should be placed on the MDT list. All the results of germline genetic testing should be reviewed at the MDM and referred to clinical genetics department for further management. Ideally, a referral to the clinical genetics department should be initiated the day the results are discussed in the MDM. The patient should be given the results by the cancer team. The clinician should explain what the result means to the patient and also what it means for their family. Surveillance recommendations should be made for the patient and for the patient's relatives. The clinical genetics department will virtually discuss the results, if appropriate, with the patient. So it's important to make sure that the clinical genetics department obtain a copy of the letter with the genetic testing result and recommendations. A positive result. A pathogenic variant is identified in a Lynch syndrome gene. If the patient is found to carry a pathogenic variant in a Lynch syndrome gene, this confirms the diagnosis of Lynch syndrome. The patient should be given advice about the recommended surveillance for Lynch syndrome and the management of their at-risk relatives. The patient should be informed they will be referred to the clinical genetics department to discuss the results further. If the result is positive, the clinical genetics department will always give an appointment to the patient to facilitate predictive genetic testing for the patient's first-degree relatives and to make surveillance recommendations. A negative result. A pathogenic variant has not been identified in a Lynch syndrome gene. If a pathogenic variant is not identified in the patient, they are less likely to have a diagnosis of Lynch syndrome. However, they will be managed in a Lynch-like syndrome category for now. In some cases, the clinical genetics department might perform some further testing in the tumour to clarify if it is indeed Lynch syndrome or sporadic. The patient should be given advice about the recommended surveillance for Lynch-like syndrome and the management of their at-risk relatives. The patient should be informed they will be referred to the clinical genetics department, who will only give them an appointment if appropriate. For example, if they can offer further testing in the tumour or in the blood sample. In any case, they will keep the case under review. For this reason, it is important to highlight that the patient may be contacted in the future. A variant of unknown significance. If the patient is found to carry a variant of unknown significance in a Lynch syndrome gene, this means we are currently unclear whether the gene variant is benign or likely to be responsible for their cancer. It is important to know that gene variants are very common, and the vast majority of gene variants are not disease-causing or pathogenic. Management and recommendations for first-degree family members are the same as if no alteration has been found for Lynch syndrome. The patient should be given advice about the recommended surveillance for Lynch-like syndrome and recommendations for their at-risk relatives. Predictive testing will not be offered to relatives. Again, the patient should be informed they will be referred to the clinical genetics department, who will only give them an appointment if appropriate. However, the clinical genetics department will keep their case under review and may contact them in the future. If you would like to access the guidelines for the management of Lynch syndrome from the British Society of Gastroenterology and the Association of Coloproctology of Great Britain and Ireland, you can follow this link, which will give you access to the article. The link will be available in our dedicated supporting documents webpage in the RM Partners website. Colonoscopy surveillance recommendations for Lynch syndrome patients. If the patient has a positive result, these are the surveillance guidelines based on the patient's genetic alteration. Patients and their first-degree relatives, i.e. parents, siblings, and children, should have a colonoscopy every 2 years. Colonoscopies should start at the age of 25 for MLH1 or MSH2 gene carriers, and from the age of 35 for MSH6 and PMS2 gene carriers. If you would like access to the guidelines for the management of gynecological cancers in Lynch syndrome from the Manchester Consensus Group, you can follow this link. The guidelines are also available in our dedicated Lynch syndrome supporting documents webpage in the RM Partners website. Currently, there is limited evidence of the utility of gynecological surveillance for early detection of endometrial and ovarian cancer. Symptoms may be an effective means of identifying problems. However, surveillance and surgery should be discussed at the appropriate age with all Lynch syndrome patients and female family members at risk. Discussion about risk-reducing hysterectomy and removal of fallopian tubes and ovaries may be offered to women with Lynch syndrome. Generally, this is offered because there is no effective screening test. However, this should be a personalized decision, generally offered from the age of 40 once they have completed families, taking into consideration their risk factors, familial pathogenic variant, personal preferences, and quality of life. In addition to regular colonoscopy and risk-reducing surgery, the cancer risk in Lynch syndrome can be managed by aspirin. A low-dose aspirin is recommended to be taken daily for at least 2 years. This has been shown by the CAP2 randomized control trial to reduce the long-term risk of cancer in individuals with Lynch syndrome by approximately 50%. One-off screening for Helicobacter pylori. Eradication reduces the lifetime risk of gastric cancer by up to half. You have now reached the end of the teaching module, which is the last module for mainstreamers. Please refer to the supporting documents that can be accessed in the dedicated training RM Partners webpage for further information. You can now email Laura Monjer Garcia to arrange further training.